Good morning. I was really delighted to be here, and I thanked the ChildKind group for giving me the opportunity to come and talk about my institution. And then when I saw who I was speaking after this morning, my heart sunk. I'm like, oh my gosh, it's really hard to follow Stefan because A, he's very charming, B, has a great accent, C, he uses the words groovy, and then he embeds all of these wonderful videos. So a little challenging, but I'll do my best. So I'm very grateful to be able to tell the story. I think fundamentally we're all committed to children's comfort as a cornerstone of the care of every institution. But every institution is different. So telling the story of how you go through the process, I think, is fundamentally really important, because since your institution is unique, the way you achieve these goals and the way you adapt to address your shortcomings is really also very unique. So that's why I'm going to tell our story. And hopefully it'll be a little bit entertaining and a little bit of an illumination of how we went about it. So Cleveland has a children's hospital. It's called Rainbow Babies and Children's Hospital. It's a 250-bed acute care hospital located within a larger adult facility, part of the University Health Systems complex associated with Case Western Reserve University. Its history harkens back to that philanthropic area when we had many civic-minded families within the city that really were interested in improving the health and welfare of children. So in 1887, on Thanksgiving Day, you can imagine these big families getting together to celebrate. There were 9 young women from those families who endeavored to move forward with this, and they created the the Rainbow Circle of King's Daughters, a small philanthropic group. And in 1901, they built the first facility in that city dedicated to care of children, and it was called the Rainbow Cottage. Now, if you move forward a full century, this is our hospital now. You can imagine there are several accomplishments in that intervening time period, but there really wasn't a coordinated way to address the prevention of pain, the assessment of pain, and the management of pain at our institution. So we really didn't have any embodiment of all of the ChildKind principles. In 2010, we had a newly hired palliative care physician, Lisa Humphrey, and an anesthesiologist named John Stork, and myself. We found ourselves together at the same table. None of us knew we were going. We went to the pain master class in Minneapolis, and we're like, what are you doing here? Well, I don't know, what are you doing here? And it turns out Lisa, obviously wanted to come and learn from Stefan at that master class. John Stork, who's my anesthesia colleague, was board certified in peds, nephrology, internal medicine, and anesthesia. And I think he just had another 4th or 5th midlife crisis. He wanted to learn something different. And essentially it was the same thing with me. I really kind of had an interest in learning something new. And as we were sitting around the table through the week, we really understood that we needed to devise a very comprehensive program. John and I weren't going to just go back and actually do blocks for a living. We really needed a comprehensive strategy about how to prevent pain and assess pain and manage pain. And we knew that we actually had a lot of literature to evaluate, thanks to many of the experts in the room. And in particular, when we looked at Dr. Schechter's papers on the Ouchless Place and then transitioning to Comfort Central, we realized we needed an oversight body, and that was the Pediatric Pain Council. So we created that. It was comprised of many stakeholders at our institution, and they helped us to move forward to really think about how we wanted to create our service, what kind of order sets, admission guidelines, educational initiatives, how to collaborate with our colleagues, so on and so forth. So how did we take all of those very theoretical ideas and actually bring them to the bedside? And our hospital was embarking in the Ohio collaborative, a 6-hospital collaborative that really took to heart quality principles, brought them to many aspects of the hospital. And so we kind of organized what we were doing based on those quality principles. and I'm sure you all know them, whether you enjoy reading about them or not, or enjoy working with your quality care center or not, that's beside the point. But this is really what we sort of organized our approach to be. At this juncture, 2010, we had hired 2 nurse practitioners, a program coordinator, and there was myself and John Stork, our anesthesiologist. And we endeavored to spend that time between August 2010, and we chose January 1st, 2011, then we realized, well, that's New Year's Day. We don't want to start New Year's Day. So we'll start January 2nd, which was Monday. So we spent the intervening time period really creating what we thought that our program should look like. And I really have to stop and say thank you to many of you within the room that are the experts in the world of pediatric pain. The literature you've created was fantastic. It guided us. You were always available by phone, by email, and as well, I don't know what everyone's background in the room is, but within the pediatric pain world, the ability to get programmatic materials, examples of order sets, examples of what has not worked for you and what has worked better. These people in this world are incredibly generous with their materials, so thank you very much. We would not have been where we are without you. So the next few slides, I really actually want to kind of take you through each category and sort of share with you what our steps were and why we went about them. So again, in 2011, no existing pain service. Anyone who had, for example, a ruptured appendix and was going to go to the operating room would come into the ED and would get restrained, probably with the papoose board as they have their IV placed and their labs drawn, and might sit in the ED for a couple hours waiting for the OR to open up, probably might get an IM shot of Demerol or who knows what all else. Go to the OR. In the pack, you probably get some parenteral medication. Go to the floor, and the orders would be like, you know, Tylenol PRN this, morphine PRN that. That patient could have one of 3 different pain scales applied through the course of their admission, and probably would have no discharge instructions whatsoever about pain management. That was our baseline. So we knew that once we started, we would begin to use many medications, primarily opioids for severe pain and regional anesthesia in a pretty widespread fashion where it hadn't happened before. So we knew that we had to put some sort of safety mechanisms in place, and we decided that initially the order sets associated with these medications would be constrained. Only the pediatric pain service, anesthesia, and palliative care would have access to these order sets. We also created and put in place policies and procedures to help guide our prescribers, to help guide our pharmacists and guide our nursing staff, primarily really focused on patient assessment, patient monitoring, and triggers for provider notification. We hope that putting these things in place would create sort of prescriber consensus. So we would have consistent prescribing practices such that when things were ordered that were not like what they used to be, it would really trigger the nursing staff and the pharmacist to give us a page and go, you might want to check these orders. We also knew that we needed educational initiatives through anyone in the institution that was going to be taking care of patients, just to let them know what we were going to be doing, what our goals were, so on and so forth. And we did this in a variety of different platforms. One of the things that we clearly learned, John and I, we were not young, we weren't any younger 5 years ago. The way people learn is very different than the way we were taught and the way we learned. And we found it very helpful to include our fellowship coordinators, our fellowship directors, and our residency directors to help us create learning platforms that they knew that the house staff and the younger trainees would be more likely to learn by. Effective care. Well, again, remember we said we started at the beginning. We had absolutely nothing. So the best way to be able to understand whether you're effective or not is to measure something. And how do we measure pain? That was really the very beginning. You would think, really? Like, how simple? Nothing existed? No, nothing existed. So again, we went to the literature and we created policy and procedure and embedded these scales and the frequency of assessment all within the EMR. So what does that mean? That means that your drop-down menu for pain scale selection might look different if you're in the NICU or a neonatal step-down versus what it looks like on a regular floor. And there were additional scales that we added for sedation and weaning and withdrawal later on. And I will say, remember Stefan's sentiment, you know, you'd sit in a room with these people and say, we'd like to do this. And this was everyone's body language, literally around the table. And you had to take a big breath and go, and for John and I in particular, it was a little difficult because we're anesthesiologists and intensivists. We're not really used to asking. We're kind of used to telling. And this was a very, very different paradigm for us to really build by collaboration and consensus. But that's really what we had to do. And these were the other things that we developed to assist us putting these documentation pieces in the flow sheet and then developing these comprehensive order sets. And we are now at the point where we no longer actually have to go and beg for consults. We very routinely get consults from certain medical subspecialties and surgical subspecialties because we have been able to demonstrate that we are a value-added service. Patient and family-centered. This is thankfully a domain that we were already, I think, pretty adept at. Rainbow has a very long history of having a multiplicity of child life specialists at our institution. We literally have at least one, if not more, for each clinical division. And we've had a very robust family advisory council. These really were our champions for us on the clinical divisions at the patient bedside. And so we were very lucky to have them engaged with us. However, despite the fact that they have a long history at our institution, pain prevention, pain assessment, and pain management really hadn't been their focus, sadly. And so despite their existence, they really hadn't had that as their focus. And as we spoke with them more, it really became clear they didn't actually feel like they were adequately engaged with the nursing staff or the physician provider staff. So we made a particular point to engage them as champions with us as part of the team, and they were consistent participants on our pediatric pain council. We also aligned with them to promote something called the comfort measures, which is very reminiscent of what you've already heard this morning. And that is a specific constellation of approaches using comfort positioning, distraction techniques that had kind of existed, had been developed in the 60s, 70s, and really no one had paid attention to at our institution. The child life specialists and the family advisory council were trying to reinvigorate that, and as we came along, it formed a really necessary partnership. So timeliness, timely delivery of care is always a challenge, particularly in an academic center. There always seems to be lots of roadblocks and lots of siloed centers. But we recognize that pain can pretty much be experienced by any child at any touch point along the provision of care, whether you're on main campus or an urgent care or an outpatient laboratory. And we knew that this could happen 24/7, 365. That was the ultimate goal, getting to be at that point where we could hit all of those touch points. But we recognized at the very beginning, we really actually needed to be focused first on main campus, which is where the entire team had a physical presence, but endeavoring to support those people on the satellite areas, whether it was by a phone consultation, whether it was by educational outreach, and thankfully we all shared the same EMR, so we were able to support them in that way. So efficient care. Being proactive regarding patient consultation would minimize the delay associated with effective management. So we developed mandatory consults and pain management protocols, and we essentially defined the acute pain and the severe pain as that patient population we really wanted to make sure we were involved with 100% of the time. And the way that we did that was we decided that there were for sure elective surgical procedures that would fit that bill. And we wanted to be involved in patient care. So we went through and we looked at the surgical lists and the patients that we either heard about or that the administration or nursing leadership definitely knew were not getting good, consistent care on the floor. And with the empowerment of our senior leadership and the surgeon-in-chief, we developed a list of surgical procedures that required mandatory consults. And we got very good at trolling the OR lists, as well as dealing with the nursing admissions coordinator. And we were able to be involved with all of these consultations. And now actually it's the rare situation, but still occasionally we get a phone call, and oftentimes now it's actually not from the surgeon, it's from the nursing coordinator on the floor, or it's from the anesthesiologist that says, oh, by the way, I'm not sure if you've got notification or consultation by the service yet, but this patient will be admitted, and this patient. So we're very grateful for their support in that regard. Equitable care, that was absolutely a fundamental aspect of our mission, as it is, I'm sure, with many of your institutions. It doesn't really matter where you get your care, who your provider is, or what your underlying disease is. You should be able to have access to pain management services no matter where you are in the institution. And everything that can be done should be done to make sure that pain prevention and pain management is a critical part of your care. And I think these are just some basic descriptors of what exactly that means. And particularly, I'm sure most of you practice, I would say, in urban settings. Yeah, again, it shouldn't really matter where you come from as a patient. If you hit the institution, you should be able to receive the same kind of care. And our translation of that was to ensure that anyone in the institution taking care of a patient, whether you're a nurse, whether you're a physician, a resident, a child life specialist, a lab worker, or even we found actually tentatively, not tentatively, a environmental services worker would pass by this young child's room several times a day, and it was very clear that that child was not getting the pain management he needed. And tentatively, that that environmental services worker went to the nurse that he knew and said, is there anyone you can call, because I don't think that this is working. So clearly we managed to get that to permeate through to the institution. So those were the things that we worked on from January 2011 to about the end of 2015. And we had identified through that period of time some programmatic challenges that we still felt needed to be addressed. We had experienced an erosion of the level of attentiveness. I mean, it was super awesome, to quote Stefan, it was very sexy at the very beginning. Everyone wanted to be involved and be a champion, but over time that had kind of waned. There was some complacency in some bedside care providers, some clinical divisions. We would hear that in their voices when we would try to actually convince them to do the right thing. There were attempts to access our restricted order sets. Well, it looks really simple. We should be able to do it. You guys did it. And again, part of an academic center, you have turnover in nursing and physician providers. So we knew that we needed to continue to be very focused on our educational efforts also. So sustainability of our program, as well as programmatic growth, really became some areas to focus on. We decided that applying for ChildKind accreditation would be an asset to us. It would allow us to evaluate our strengths, evaluate our focus, our weaknesses, and hopefully get our senior leadership to collaborate with us on focusing on our new programmatic growth and programmatic change. So we crossed our fingers and off we went. And before I go any further and sort of take you through our process, I want to tell you the application was daunting. I can remember looking at it going, oh, just 5 principles, meh. And then I started going through the application. I'm like, ay. Unfortunately, by then, we'd already made it public. No going back. But I will tell you that the individuals behind the application made it really very easy, and were very supportive, and we're incredibly grateful that we went through it. So we decided that we would evaluate our pain service in kind of 2 goals in mind. We wanted to be able to convey our journey, how we began, how we started, and what had happened in the ensuing pretty short period of time. I mean, literally from January 2011 to when we decided to apply, which was the beginning of 16. And we wanted to also represent our service strength, as well as equally show our weaknesses, because we knew we wanted help. So we decided that the site visit would be the way that we told the story, and that the application would be the way that we shared our institutional policy and procedure and supporting documentation. We had recently instituted a green initiative at our hospital, so we didn't want to create these big paper packets and ship them wherever they were supposed to go. We thought that we would actually create an ebook with chapters and provide examples of supporting documentation that way, and it would kind of maybe make it easier to cross-reference the materials that were requested, because there were many of those areas in the application that to us seemed to sort of overlap to some degree. So we created this ebook, and we loaded it onto jump drives and sent them off. And we received notification that we were going to be reviewed, and we underwent a site visit in October of 2016. So before I review the site visit, I wanted to just go through kind of piece by piece what it was that we included in the application, what kind of supporting documentation, and I just found it easiest to go through each principle. So that was my organizational approach. People might have different approaches, but that worked for us. So there's principle number 1. Clearly, I think the biggest feature for this application is to very definitively show that there is an institutional commitment to proceed not only with the application, but to really underscore the very existence and the programmatic future of a pain service. And you know, you saw in Neil's first slides at the beginning of the morning, you know, all sorts of different initiatives, but you really need that institutional commitment to be the glue. And included in that area, we felt it was important to show the various policies that exemplified that, and then also the onboarding examples that we used for any and all new hires, whether you're someone that's going to be taking out the trash, or whether you're someone that's actually going to be in the residency, or whether you're actually new faculty. All of these onboarding initiatives contain something specific to pain relief. Ongoing education, again, we learned a lot about how to teach, how to engage people. We used a variety of different platforms. We essentially tried to get in front of anybody that we could. So we had a variety of different educational initiatives. It got to the point where if I noticed someone in an elevator I hadn't met before, if there was someone in an elevator that was new, or if there was someone in an elevator that I thought maybe might be important to help our mission, I had a 2-minute speech. So I got to the point sometimes where I'd walk in the institution in the morning and be, hey, and people would be like, hey. Because they knew, particularly people knew that the site visit was coming, and they knew that if they smiled and engaged with me, I was going to talk about pain or something related to pain or the ChildKind accreditation. So, but anyways, so these were a multiplicity of the educational initiatives that we included. When we first started, we had a pain symposium, and it was led by the pain committee, which at our institution was really primarily nursing-led. And it was a day-long event, which was great, because if you could book off your schedule for that day, that meant that you could attend the whole day, and it wasn't that awesome. There were only 2 problems with that. The nurses, even though they were very committed to this, didn't write the orders, and none of the house staff and none of the faculty could show up for an entire day. So about 2 years into this, when we're like, no one is coming, why, I tried the carrot, I tried the stick, I tried the food, I tried tchotchkes, great little badges, I tried everything. No one was showing up. And then, I don't know, we kind of had a light bulb moment where instead of having a day, we just turned it on its side. So instead of going from 8 to 4, we went all week, and we had dedicated educational time slots, M&M, grand rounds, resident management conference. And so we said, yeah, we'd like those. Thank you. That week in October, we want every single one of those educational slots. And lo and behold, now we have lots of residents, lots of faculty, and we tied CME and the all-important risk activities so that we would encourage many of our resident and fellow and faculty. We also included competencies for clinical staff and educational materials that we had developed for our patients and families, primarily targeted to explanation of pain strategies on admission and then discharge instructions. I think this is pretty self-evident. Our various policies, how we went about training people to use the scales, our chart review, in order to assess compliance with these policies, the EMR-derived reports about compliance with the policies, and then how that translated to what we showed our institutional quality people regarding the compliance. Specific protocols. Again, did I mention that many people in the audience were very generous with their materials? We begged, borrowed, many of these things. The POKE plan is from University of Michigan. At the time that we did this, essentially it's like no needleless pain, Comfort Central, a very similar strategy. We just kind of like the diagrammatic way it was represented. Procedural pain clinical practice guidelines. When I was an intern in 1992, we did everything that you're not supposed to do. And I decided that it would have been really great when I was an intern if I actually had a resource that made it super easy to be able to help kids through procedural pain. Everything was alphabetized, so and procedure, arterial blood gas. There it was, arterial blood gas. Everything that was recommended by age, you get the gist. The one thing we learned, though, is that it's great for us to think it was a good idea. So this would be awesome, giving patients anxiolytics or analgesics or using topical medication. The biggest question we got was, well, what am I supposed to do with my patient when you're going to do this to them? How will I know if you choose the right medication? How will I know what to monitor the patient for? So we realized we had to create a minimal sedation policy to form the context wherein they could actually use the clinical practice guidelines. And we included all of these examples with our application. And the last example, quality improvement. Again, I think this is very familiar language to many of you. In our particular institution, again, since we started from nothing, we had to pay particular attention to drug adverse event monitoring, and specifically the sequelae of systemic medication, particularly opioids. This is what our institution was very interested in, and we were collaborating as an institution with the Ohio Collaborative. Part of their mission was to really look at opiate use and all the sequelae of opiate use. So that included unanticipated admission, upgrading care, constipation, readmission for constipation, those kinds of things. And the continuous monitoring that we're ongoing is those, as well as all of our patient issues are funneled through M&M process that goes through anesthesia as well as the pediatric ICU concurrently, as well as through the Rainbow hospital level QA committee. And then we have committee meetings that help us provide oversight and keep us in touch with the rest of the institution. Pediatric Pain Council, which if there's one thing that I would encourage people to do if they haven't done, this is fundamental. This makes our job so much easier because in 1 hour meeting, we started quarterly when we first started going. Now we're back to twice a year. It saves you so many phone calls and meetings and emails because you can just sit there and really talk about your ideas and what these projects should look like. And you learn many things from just in a really open forum. And then we have the pain committee and our quarterly pain service meetings, and then the planning committee for our University Hospitals Pain and Palliative Care Week. All right, so that brought us to our site visit. They had received the application, we were told we were going to be visited, and then it came the opportunity to, what do we show them when they come here? So we decided that, again, as I had said earlier, this was going to be the way that we told the story. We wanted to showcase our impact on patients, we wanted to kind of show who we collaborated with, and then we wanted to demonstrate the institutional transformation at the level of the clinical care division. So the day was opened with a presentation by our Department of Pediatrics chair, who is a neonatologist, knew me as a young baby intern and was disappointed I didn't become a neonatologist, but she said some kind words nonetheless. Our surgeon-in-chief, Dr. Barksdale, really talked about how we had collaborated with the surgeons in the development of the service. Our chief experience officer is a former critical care physician and the former director of our sedation service, really could speak to firsthand how things had gone. And then our quality officer, who's in charge of both the children's and the McDonald Women's and had participated in the baby-friendly application, she really spoke about the Quality Center and the Ohio Collaborative and our PASS report system and how the pain service could interact with that. We then went on to have a lunch with members of our adult and pediatric palliative care services who we work closely with, as well as a member from the Family Advisory Council, our Child Life members, and then the rest of the team from the pain service. And then we went on to visit our clinical divisions, a couple of fun impromptu encounters. I think Dr. Walco skewered some lab techs in the elevator and asked them questions. And then went on to the various clinical divisions. I think one of the things we didn't anticipate was that we needed to really build into the site visit the opportunity in a kind of unscripted way to interact with not just physicians and nurses and child life specialists, but lab techs in particular, or an x-ray tech, or a family. There needs to be also some spontaneous time actually built into the visit. And then at the end of the day, we were very lucky. We were able to sit down with the entire site visit team and with our institutional CMO and review the visit. Talk about the strengths of the program that they had seen, and thankfully, we were happy to display, but then also really frankly talk about the deficits. And this was really what we wanted to hear. We wanted to hear what deficits that they had seen. We knew some of them. We thought we knew all of them. But what we really wanted was we wanted to hear what their perspective was. And that was, I think, a very productive meeting. It was also followed up with a very lovely letter addressed to ourselves and the CMO and the president of the institution, where it very clearly delineated what our strengths were and what our weaknesses were, and what perhaps some of the steps might be taken to address those weaknesses. And from a medical director, I found that really very helpful. It serves for us a way to galvanize our momentum forward, and again, iterates areas that we knew we already wanted to work on. So we received accreditation in 2016, and that is the team. So, can I get the pointer to work? Oh, yes. That's Janessa Therian and Carrie Williams, our nurse practitioners. Kasha Rubin, John Stork, and Peggy Seidman, our anesthesiologist, and Susan Thomas, our program coordinator. It does not include all of the lovely people that provide patient care, all of the supportive administration, senior leadership, and many of our collaborating physicians, both in the medical and the surgical side. So it really does take a big team, but that is the small pain service. So I'm sure you're wondering, okay, fine, you did all that and you got the plaque. What does it mean? Well, I think that we can actually look at the impact of accreditation on our institution in one of two broad categories. So we were acknowledged as a functional service line with established excellence in clinical care, as well as an impact at an institutional level. We were very fortunate to receive a Rainbow Babies and Children's Foundation Award based on our clinical care, excellent clinical care in the same year. So we kind of had a good year in 2016. Anyone who has participated in the process of pursuing an application for accreditation, creating that application, and then preparing for a site visit, anyone in senior leadership or in nursing or physician leadership really knows what the energy involved in that. And so that process in and of itself, I think, was acknowledged at our institution. But I will tell you that the downstream effect subsequently has been that people now actually come to us and they want us to be involved. So imagine when a neurosurgeon, orthopedic surgeon together walked up to me and said, you know, we've been tasked with creating the Spine Institute, and we'd really like you to collaborate with us. You talking to me? But no, I mean, that's the kind of positive affirmation that all of us want. Instead of us always going out and trying to convince them that we're needed, you know, for someone to come and say, we want you to help us, you know, be at the table, have some input into what this is going to be like, that to us is probably the best affirmation of all. We've also been offered the opportunity to go through every single admission order set or perioperative order set and evaluate it for correctness, whether or not the doses are correct, the timing is correct, if it is missing something, if something should be taken away. And once we're done with that, then we're going to have the opportunity to create some ones that we think we need that are missing. And we are also collaborating, and I'm sure many of your institutions have been tasked with finding just the right message to send about opioid prescriptions, what to do, how much to give, how long should they take it when they go home, what should you do with the leftover medication. So that's one of the other opportunities for our service. So those are all the great things. Again, we did mention that there were some deficits, and we are in the process of trying to figure out how to address these deficits. Some are easier than others, some require money, some do not. We knew that the pain service required sort of an active process to ensure its longevity. And we currently, with 3 anesthesiologists and intensivists, 2 nurse practitioners, we're all kind of have different reporting structures. In order to, I think, promote longevity, we knew that we needed a new academic home, and the site surveyors very clearly agreed with us. We believe that it will also substantially increase our retention of our team members as well as enhance recruitment. And we knew that we could benefit from philanthropic support, so we are now working with the development office to try and find some support in that regards, not in place of institutional support, but in an additive fashion. That's always beneficial. And then we are finalizing a business plan to solidify our current service line composition and define its growth. We have no dedicated psychologist. We have no dedicated physician with chronic pain and palliative care experience. We have no dedicated physical therapists. We have no dedicated social workers. Anyone wants to come and work with us, see me later. Anyone who wants to give us money, see me later. But no, these are, well, maybe I'll stand in front of Stefan. But these are things that we need to hire and grow and create, and that's really going to be the dawn of the next era for us. So again, I want to thank everyone for the opportunity to come here and share our story, and thank you so much to all the experts in the audience. Thank you, thank you. And questions?
So again, I'm Neil Tyrrell from UMass Memorial. And thank you so much. That was wonderful, like a wonderful view of everything.
Sure, it's hard following him.
Yeah. Well, you did a great job.
Thank you.
Do you, could you help me understand, again, you said at the beginning, what is what Rainbow Babies looks like? Especially, I love that you were the speaker today as a children's hospital within a larger setting, because that's where most kids take care of, not, the Seattle, the Minnesota, But so within that, the crossing the lines of plastic surgery, an adult plastic surgery service taking care of children's occasionally, or any neurosurgery, anything like that. How has that been for you? And is that the structure of your hospital? That's the structure at UMass. Is we have a bunch of dedicated pediatrics, but then we have some that we have, 3 orthopedic surgeons who are pediatrics amongst a sea of adult orthopedic surgeons, and the call schedule leads to an adult orthopedic surgeon being on call, taking care of children, and a group of residents that are just general orthopedic residents who all want to provide excellent care, and in their heart, but just it doesn't happen.
Right.
Times,
Yeah, no, that's a very good question. That actually was kind of like our beginning. So we do have dedicated pediatric surgical and medical subspecialists. However, in the surgical subspecialists, the night coverage, which is where it all happens, and those are the people that write the orders, it's the house staff, they are primarily adult residents who some of them don't mind, most of them are terrified of children, and so trying to help them is really what we targeted. And that's one of the challenges is actually getting face time in front of surgical house staff is very difficult. And that was one of the compelling reasons to create these mandatory consultations. We knew that once we got in the habit of common and consistent practices, the next people that would be our champions would be the patient's caregivers, right? So the nurses and the pharmacists who would be like, no, that's not the way we do it here. No, your order's wrong. Well, what do you mean? Well, call the pain service, they'll explain it to them. So it took some time, but rather than work from just the top down, working around with nursing, pharmacy, and the resident house staff was really the way to go. And being at an academic center, there's such turnaround with resident house staff. That is something you have to commit to. You can never just kind of go, okay, I'm done. We gave you that education, we're done, figured out. It's every year. And every July and August, we're up on the floors introducing ourselves. Hi, how are you? Yeah, do you have a lanyard card? Hi, this is who I, and again, by the end of August, we know we've done our job because they're like, hey, they don't want to look at you because they've met you and they don't want to hear the speech again. But I think, getting the buy-in from the surgeon-in-chief, we're lucky because Kasha Rubin, our anesthesiologist, is also the division chief. And Ed Barksdale, the surgeon-in-chief, I've known him for a long time. So having these kind of collaborative relationships from the very beginning and exerting that kind of sphere of influence, as well as doing, all of these other ancillary type educational efforts. Yeah.